Thank you very much. So I just said before, I'm very honored to be here with you, and thank you to Dr. Cosumano for introducing me and my presentation. So the topic of my presentation is heart inoperable mass treated with radiotherapy. So I'm going to talk about two clinical cases of unresectable cardiac mass treated with radiotherapy at our institute. Next slide, please. So the first one is a 54 years old female with good general condition, only hypertension as a pathology in pharmacological therapy. Her medical history started in December 2016 with retroperitoneal mass detected by CT scan due to abdominal pain, and she underwent resection of retroperitoneal mass in other hospital, and histological diagnosis was leiomyosarcoma grade 2. She underwent in another hospital to adjuvant chemo with the sixth cycle of gemcitabine and dacarbazine, and the next restaging CT was NED. Next slide. She relapsed in November 2017 in the right inferior abdominal wall with soft tissue nodules, which was removed. Then CT scan and PET-CT performing in June 2018 show a new relapse, always in soft tissue, which was in other institute treated with SBRT, 54 grain 6 fraction in one and 48 grain in 6 fraction in the other. Then she relapsed again with plurifocal recurrence disease in the lungs and in subcutaneous nodules. And she started second-line chemo with doxorubicin and dacarbazine with partial response. In this setting, patient was managed in other hospital. In January 2020, she underwent SBRT on progressive pulmonary nodule and surgical resection of subcutaneous nodule. Next slide. Interestingly, as restaging CT on February 2020, there was evidence of progressive disease in 3 pulmonary nodules. In the was appeared a nodule in the left kidney, but important appears nodule in left ventricular site. And a cardiac MRI performed on March 2020 show this pericardial exfusion with a round mass in left ventricular cavity, 24/17/450 millimeter with a necrotic area. But important, patient started to be symptomatic for frequent ventricular arrhythmia, and amiodarone therapies was started. Then patient was referred to our institute. Next slide. We manage a patient with our colleagues of Oncologic Veneto Institute of Padua, and patient was managed with at Croaviano at our institute for radiotherapy and cardiology with Chiara Lestuzzi and me and my colleague in radiotherapy, and in Padua for medical oncology. We share case with our colleagues of Padua, and due to progressive disease at in lungs, cardiac, and kidney, we decide to start chemo with trabectedin, but we consider, because patient was symptomatic, we consider therapy, a local therapy on cardiac lesion with radiation. Patient started trabectedin, and the second cycle of trabectedin, we start volumetric modulated arc therapy with image-guided radiotherapy on cardiac mass, 44 gray in 22 fraction, and simultaneous integrated boost to gross tumor of 55 gray. As Dr. Lestoussis have said before, radiotherapy, cardiac radiotherapy is a challenge due to the critical site, but also for the lung motion, cardiac motion, and lesion motion. So we have integrated for radiotherapy planning, we have integrated the echocardiograph to study and consider lesion motion with basal cardiac MRI and cardiac CT, as well as respiratory motion by means of simulation CT with respiratory gating. Next slide. We obtain a PET CT of patient that we have fused with a tax simulation, and also with tax simulation with respiratory gating, and with the cardiac MRI and cardiac CT to better define the target volume. We defined our target area. Next slide. We have defined the target area PTV1 in blue, this one, and PTV2, the simultaneous integrated boost, using the movement of echocardiography. In this slide, we can see the PTV and the cardiac structure, and fuse with the simulation CT. Next slide.
May I ask a question? May I ask a question? Can you go back to that last slide?
The mass?
This one here. This one here. Are the red things in the soft tissue? Do you think those are metastases, or just what do you think those are?
This is metastasis of
the soft tissue.
Okay, you mean in the other ones, in the bones and soft tissue?
Yeah, in the bone and soft tissue.
This is not a PET. Just the yellow one,
it's not
metastasis.
That's not a PET.
The red one. What are the red one?
The red one is a cardiac metastasis in a CT PET fused with our CT simulation.
So what I'm asking is that are those things, do you think in the bones she has multiple mets in her bones?
No, no.
Soft tissue?
No. She has only 3 nodules in the lungs, 1 nodule in the heart, and 1 nodule in the in the left kidney. So we decide, because she has metastatic disease, she has to start chemo. But because she was symptomatic to the heart, because she have frequent ventricular arrhythmia, we decided to local treatment, and we decide to use the radiation for heart lesion. And so to better define the volume, we fused the PET CT with our tax simulations, with our CT simulation.
And did you give this before the chemotherapy?
Yeah, I don't understand.
Did you give it before the chemotherapy? Did you give
concomitant with chemo?
Yeah, well, here's the problem.
At the same time?
Same time. Because you gave the chemotherapy, sorry, you gave the radiation because of arrhythmias.
Yeah.
Would you expect the arrhythmias to go away with chemotherapy, or why did you use radiation? Just because to get it faster?
We use the combination with trabectedin because trabectedin is active in the metastatic lesion in the lungs and in the heart and in the left kidney, but also trabectedin has a radiosensitizing effect.
Yes.
So our goal was treated her with using the radiosensitive effect of trabectedin that cover also metastatic disease. This was our discussion with Dr. Lestuzzi and Padua medical oncologist colleagues. Next slide. This is another example of fusion of CT stimulation CT with the respiratory gating and CT PET. Next slide. This in the same planning we have fused also basal cardiac CT. Next slide. And as I said before, to define the expansion of our target, because a cardiac lesion move during radiotherapy, we use the integration with echocardiography that Dr. Lestuzzi made, and the total movement of lesion is 14 millimeters. Next slide. This is our radiotherapy planning. We can see in the first figure the optimal coverage of target at the isodose of 95% of the prescriptive dose. The second figure, you can see the isodose of 50%. So we can see the optimal spare of surrounding cardiac structure, left ventricular, right ventricular, right and the left atrium, and spine. And in the last figure, you can see the histogram dose volume with the optimal coverage of the target. Next slide. During the radiochemotherapy treatment, we perform a daily electrocardiography and Holter in the first week, always negative for arrhythmia. So, with Dr. Lestuzzi, we decided to perform weekly Holter and electrocardiography with the medical examination blood test. Next slide. After the side effect during radiochemo, the principal side effect was nausea grade 2, grade 3, but controlled with antiemetic therapy, anemia grade 1, and asthenia grade 1. So treatment was well tolerated. In June 2020, after radiochemotherapy, cardiac MRIs show the stability of the metastasis in left ventricular cavity. There was a good hemodynamic compensation with the left ventricular ejection fraction 65%, but there were no more episodes of arrhythmia, and so we decided to stop amiodarone. Next slide. This is a CT, angio-CT, cardiac CT performed in July 2020 and in February 2021 when patient continuing trabectedin. Next slide. Currently, from October 2020 and September 2021, she had progressive disease in distant side, but always in a few sides. So we can consider a slow disease, a very slow disease. And she underwent SBRT, chemo, and other surgery. Dr. Lestuzzi visited the patient in January 2022, and she has progressive disease in distant site, small fibrotic area in left ventricular wall, but no episode of arrhythmia, and she is free from amiodarone. Next slide. The second case is a 66-year-old male, former smoker.
Perhaps we can stop and ask for comments about the first case so we don't forget the first case.
Okay.
Okay, so it looks as though, can you go back to your slide? The tumor there, it looks like it went away, but on CT scan, did it go away or no?
Sorry, the CT scan?
Did the tumor regress in size? Same size?
During treatment, the last CT scan detected a small shrinkage of a tumor, but at the echocardiography of Dr. Lestuzzi documented a fibrosis of nodule.
And
correct?
Actually, okay, actually, I saw during the treatment, the radiotherapy, the echogenicity of the mass changed. So, and this is, we have seen this before in other tumors. So the mass maybe doesn't change so much in size, but it changes in echogenicity and evolve to fibrosis. I think that she didn't have a CT scan with cardiac synchronization, allowing exact analysis of the cardiac of the ventricular metastasis, because at echo it disappeared, and actually it's just a hyperechogenic part into the myocardial wall and the left ventricular wall, and so it appears to be fibrotic, but in this case, I just looked with echo, because the CT scan was performed mostly for evaluating the lung lesions. So maybe if you have a CT scan not synchronized to the ECG, the mass may seem larger than what actually is. Because in echo, I have no doubt that it's gone.
The reason I asked that for is because sometimes a person will have an obstructing tumor, and you showed in your talk how the tumor essentially melted away completely, and that's a complete response. And when you have a response, do you ever see it? For instance, the last tumor we saw in the heart was a big, almost filling the whole right ventricle. If you were to irradiate that, would you expect it to go half away, a quarter away, 3/4 away, or all the way? I mean, complete response is all the way, but you say that sometimes you don't get much loss of the actual volume of the tumor, but you get a difference in the quality of the tumor. Is that correct?
Yes. Yes. It's difficult, but anyway, I think that as in the case we have published with right ventricular metastasis for mantle-sarcoma, also in that case we saw a worsening of left ventricular arrhythmias as soon as the tumor started to grow up. And we saw an increase in ventricular arrhythmias when the size of the tumor was still the same, but the uptake at the PET was increased. So maybe in these tumors, there is not only a mass effect, but also some activity, something produced by the tumor that is induce arrhythmias. So in this particular case, after removing the amiodarone, the lady is still free from arrhythmias. And also when we started trabectedin, her arrhythmias were still worsening. This was one of the reasons why we decided to go with radiotherapy on that lesion, because the risk of arrhythmias.
If she had any more tumors in her heart with the metastatic disease that she has, obviously you're not going to operate. But if she had a tumor on, say, the right ventricle distant from that tumor, would you irradiate the rest of the heart, or is that enough radiation for her whole heart? Based on your gradient, based on your X-ray gradients, radiation gradients.
But,
do you understand what I'm saying? You gave this lady radiation to the free wall or to the apex of her left ventricle, correct?
Yeah.
Yes.
And so would you give a radiation to other parts of her heart too, or that's finished?
Yes.
Yeah.
Yes, yes.
The gradients fall off very rapidly, do they?
Yes.
Yeah. Okay. And then the final question I have is, go ahead, you want to answer?
Yeah, and what was the goal of planning the radiation was to spare the interventricular septum. This was my, I expected to have some adverse effect on the free wall, but the important thing was to avoid radiation of the septum. In fact, in the plan, the interventricular septum was always spared. Actually, the ejection fraction is normal now, but the global strain is altered in this patient. So this is not a normal heart. There is something that is gone, but it's like
cancer in it. Now it's
all the myocardial infarction, not a transmural myocardial infarction.
And can you tell us again how you use the echo? I mean, you show the motion of the heart. You don't gate the radiation to the heart, do you? It's not gated radiation.
No.
How do you use the echo again? I didn't quite understand how you use that.
We try to obtain, I suggest I show the moving, and they try to have the tumor be within the radiation field throughout the whole movement. Putting
I see. So you tell them it moves this much.
To avoid that a part of tumor goes out of the radiation field. So in this particular case, to keep the radiation field a few millimeters from the interventricular septum, and try to see through the cardiac cycle how long the mass stay in the radiation field.
Right.
It's not a simple task.
No.
In radiotherapy planning, we define the target always with Chiara, with the integrated the data of echocardiography for expansion, for give the expansion of volume.
And how long does the beam stay on when you turn on a beam per day?
How long is the radiotherapy delivered?
Yes, per day, each day.
Each day is a patient 22 fraction, and every day the therapy is about 14 minutes.
That long?
Yes, 15 minutes.
Yeah. Okay.
Because every day we perform perform an image guide radiotherapy for setup patient, and totally are 15 minutes. In tomotherapy is more long, also 20-25 minutes.
Wow. And in this patient, you used chemo, you used the radial sensitizing agent, which also acted as an agent specifically for the metastatic disease. If you didn't have metastatic disease, do you normally use radial sensitizing medications?
Generally, we use, in this case, the combination with trabectedin.
In this case, but what about in a case where they don't have other metastatic disease? Do you always try to use a radial sensitizing drug?
No.
No.
Just coincidence here.
But there is not much literature about the use of radiosensitizing agents.
Yeah, that's why I asked the question.
We use the trabectedin because we have data in soft tissue sarcoma from TRUST trial. TRUST trial is a trial of a combination of trabectedin and radiation in soft tissue sarcoma of extremity and trunk, superficial trunk, but also the cohort B explore the combination in lung metastases. So in this case, the combination, according to the patient, was to control metastatic disease. In particular, the radiosensitizer effect is for cardiac lesion, but we decided to take patient cover of metastatic disease during radiotherapy treatment, because in during radiotherapy treatment, patient disease could spread.
Yes, actually, we have, when Dr. Navarria was not working yet, many years ago, we had a case of angiosarcoma infiltrating the right heart, which had poor response to chemotherapy and was stable, as a stable disease, not reactive. So we tried radiotherapy, but during the month of radiotherapy, we stopped the chemotherapy, and he developed brain metastasis and died 1 month later. So the problem is, if you have a metastatic disease, not to stop the chemotherapy for the metastasis in the months you need for radiotherapy, if it's not a contraindication, because sometimes maybe chemotherapy may be contraindication. So and there is nothing in the literature stating what is better. This is one of the reasons why I'm very happy of the project of Interact, because we need to put together all this experience, because we made a personal plan time after time in each patient, and each patient was different from the others.
Yeah.
Another thing, we choose trabectedin in this case because we know that trabectedin is active in L sarcoma, lipo and leiomyo. So she just underwent to dacarbazine and doxorubicin. So the third line, because the trabectedin in this case is a third line therapy, is third line chemo, was safe with concomitant radiation. So this is another another this is the principal thing, because we have choose trabectedin.
On the other hand, if the first choice of chemotherapy was anthracyclines, as is in many sarcomas, I wouldn't use anthracyclines together with radiation therapy on the other hand, because we know that the two together are much more cardiotoxic. So you have to balance the risk of metastasis, the risk of adverse effects, and to choose according to which is most appropriate chemotherapy for that particular tumor. And sarcomas are really a world of tumors. There is no standard therapy.
Okay, thank you. Carry on.
So case 2, the second case is a 66-year-old man in good general condition, former smoker until 2000. His medical history started in January 2018 with the diagnosis of non-small cell lung cancer, CT2-CN2. He started chemo with the platinum plus pemetrexed for 3 cycles from March to May 2018, but for progressing disease in May 2018, he stopped chemo and started atezolizumab. And in June 2018, he underwent mediastinal radiation to a symptomatic lesion. Next slide. In October 2018, a PET-CT showed a partial response, in particular a regression of uptake in nodule lungs, but a new uptake in hepatic site, adrenal, bone, and a small uptake area in the left ventricular wall near the apex. But at the echocardiogram performed on December 2018, there were no abnormal kinetics corresponding to PET uptake. On February 2019, he complained dizziness when standing up and palpitation, and was admitted in different hospitals with a ventricular arrhythmia. At echocardiography, detected atypical masses in the left ventricle, and with differential diagnosis between thrombus or metastasis. And the CT scan show a large mass in the left ventricular with infiltration of the left ventricular wall, mediastinal metastasis near the pulmonary artery, liver and adrenal metastasis. Cardiac MRI confirmed the left ventricular mass, suggestive of neoplastic disease. Next slide. At CT scan, we can see the mass in left ventricular wall. Next slide. Also, cardiac MRI show the mass in ventricular, the left ventricular wall. Next slide. Next slide. This is an MRI that we use to perform radiotherapy planning. Next slide. But patient was referred to our institute in cardiac surgery, and he was operated on April 2018. But at surgery, the mass was nearly double compared to the beginning, and the histological diagnosis revealed a high-grade spindle cell sarcoma. Next slide. So patient was referred at our institute. In our team sarcoma, because a patient at the beginning of his diagnosis was managed at our colleagues who treated non-small cell lung cancer. This is Dr. Lestuzzi echocardiography that show progressive disease, a regrowth of tumor after 1 month. Next slide.
Can I ask a question? And I'd like to ask Robin Jones what he would do now. I want to see if what would Robin Jones have done after the first tumor? Would you have sent him to the OR? What would you have done?
Yeah, I think I really like the approach that
small cell sarcoma, or small cell, of his lung. Now he has something in his heart. I
think we have a very similar approach. Going back to the. Can you hear me?
Yes.
I really liked your approach to the previous case using trabectedin and radiation together. And I think that's something that we don't do often in the UK. And I think that you illustrated the case really well there, and the benefit of using that multidisciplinary approach. So I that's really sort of struck me, and I think it's something that we should consider more often. So I really like the way that you did that, and we probably would have approached that slightly differently. I'd say in this case, we would probably have treated in a similar way, basically.
And what about now? What would you do now that he has this recurrence so quickly?
If there's a rapid recurrence, we'd usually consider alternative systemic therapy in a way just to gauge the tempo of the disease, and then consolidate with local therapy. But again, I think the context can be challenging, but in general, that would be our principle, to try and consolidate with systemic therapy with another local approach.
Yeah, actually, since I've followed the patient, actually I was against surgery, because the problem was that the patient was already on immunotherapy for his lung cancer. And the mass, in my opinion, was unresectable. In fact, the cardiac surgeon did just the debulking. And when unfortunately, the patient was not in our hospital, was in a different hospital. And they decided to operate, thinking that a debulking was something useful. And then I would have pressed to have a biopsy in this case, in this particular case, because the clinical history was not consistent with a lung metastasis. It was very strange, because the lung lesions were growing slowly. This patient had an echo in December, and was made by myself. Probably I made a mistake. I missed a very small mass, but the mass grew so quickly in 2 months while he was still under immunotherapy for his lung tumor. And this was strange because the other metastases were not growing so fast. So we didn't think actually to a second tumor was strange, but anyway, there was something strange in this patient. And try a debulking. I think that a debulking was is always without any sense. So I think I would have done. I personally would have suggested a biopsy, maybe a mini invasive biopsy if it's not was not possible, and to think with a biopsy with a histologic diagnosis. Is this why in the other case of the metastasis of liposarcoma, I said I will look for a biopsy if possible, because you never can say.
Yeah, that's a really good point, Chiara. That's a really, really good point. And I've had patients with metastatic disease previously, where, as you say, the clinical, the scenario doesn't quite sit. It doesn't make sense. And I've gone back and done a biopsy, and something completely surprising has been found. So I fully take your point.
When you found, did you get this patient at this time, Chiara, or when you first did the operation? In other words, were you planning to give him some systemic therapy, but this grew so fast?
I saw him the first time when the first PET was observed in December. And I saw him at the beginning of January, and I didn't see anything strange in the heart. So I looked carefully to the cardiac apex, and I didn't see anything. And now I apologize and I blame myself because I had to ask for MRI. Now thinking I made a big mistake. I had to ask also for MRI because there was an uptake near the apex, and it was suspect. And I was happy for the patient to don't find anything. When the mass grew up and he had dizziness and syncope, he went in a different hospital, and they didn't ask me my opinion. They followed the patient and they decided to send the patient to the cardiac surgeon. Actually, I presented this case before surgery at the cardiac tumor board, and when I said they have decided to send the patient to the cardiac surgeon, I remember Dr. Riordan jumping on the seat and saying, "Why?"
Yeah, I said the same thing. I remember.
and this was the mistake of it was a heart team composed by cardiologists and a surgeon who never, without any experience in malignant tumors. Maybe if were another cardiac surgeon with some experience, would be. So I saw the patient later after the surgery.
And you were planning, in addition to radiotherapy, to give some systemic therapy as well? And
we planned the radiotherapy this way. I heard of the patients by some colleagues, but not unofficially. And they said, my first suggestion was to have a biopsy or anyway to make radiotherapy. Yeah. Because it was a huge mass, not resectable. Why try a debulking? This is in a rapidly growing mass.
You can consider debulking or a biopsy, an open biopsy.
Yeah. because the problem with this mass that it was not the first finding.
Yeah.
We knew that the mass was very small at the beginning of January and was very large at the beginning of March.
Yeah.
So in 2 months, and this is why I said, okay, it's a rapidly growing mass. Maybe it's a metastasis. Okay, go ahead with radiotherapy. And they also lost a lot of time doing the preparation for surgery. They lost, so it was the typical case of driven by cardiologists and cardiac surgeons without experience in cardiac tumors. With another team would have done something different.
Chiara, can I ask you just one question? How was the collaboration done with medical imaging in this particular case? Was it done a CT scan? I don't think you have shown this. Was it done with contrast, without? Was there a formal report? Just understanding how this collaboration would have potentially prevented from us from, or you from a delayed response.
Was a problem. Because I had an unofficial news about this patient by some colleagues, but the top decided not to share the case with me.
Okay.
And this is what happens sometimes. It's a hard thing. I will explain you in private.
No need.
It was really something disappointing for me, because I know we are in a small region. We see, and it's always disappointing when you give a suggestion and the suggestion is not followed because it's not.
I hear you. The point I'm trying to make from the imaging point of view is, and I think that is of value for those who want to know how to image those cases, is we do have a pressure for imaging without contrast material, and it comes from the fact that there are some rumors it could damage and kidney function, etc. The reality is, I mean, this is an extreme case and it's a rare case, but for those who set up imaging protocols, it is a true fact that if we compromise on the technicality of how to image patients, we run an increased risk of catching those important and sometimes unexpected findings. And that's an important message I would like to bring across. If a cancer patient is to be staged, we should actually do the best we can because those cases will otherwise slip through.
Yeah, in fact, I think I believe in collaboration. So I don't say this patient must be undergo, as when Dr. Cusimano asked me, will you make radiation therapy on the relapsing tumor in the atrium? I said, okay, if there is no surgical possibility, I will think to. I think that is like a puzzle. Everybody must put his little piece and put the puzzle together. And I have so if I ask to one radiologist to have something, a few days ago I asked a radiologist to have a CT scan for a particular problem, and he did his best. I had a patient with myocardial metastasis close to the descending anterior descending artery and coronary artery, and I asked a CT scan to see how much the metastasis was compressing the coronary artery, and he did for me. So this is a good collaboration between physicians. The problem is the cooperation between institutions.
Yes.
And this is the big problem. If one institution says, no, we are the best, we don't want lessons from others, this is this is what the patient doesn't need. The patient needs the cooperation with humility also from everybody.
Yes, the problem in this patient was that he started the oncological therapy in our institute, but for symptomatic heart disease was managed in other institute. And then when after cardiac surgery operate patient and the histological diagnosis was sarcoma, he come back to our institute. And with Chiara and our colleagues of multidisciplinary sarcoma tumor board, we decided to treat the regulation with definitive radiotherapy with conventional fractionated. And as I previously said, we consider the cardiac motion, echocardio for cardiac and lesion motion, integrate with cardiac MRI and cardiac CT, the PET, but also the CT with respiratory gating for respiratory motion. Next slide. This, Chiara, if you want to comment.
Yes, this is just one slide. It's not the best one, but we use also in this particular case 3D echo to show the movement of the mass to better understand, even if normal echocardiogram may be enough. This patient, unfortunately, had also both a poor cardiac echocardiographic window and a poor vision of the tumor, because you see the tumor is a low echogenicity. If you see on the left, it's hard to say the mass, which was really large, but it's maybe confused with normal echoes. The 3D images were helpful in better visualization of the mass. Okay, this was just one of the things are put together in the planning.
Next slide. For this patient, we decide to treat with not with volumetric arc therapy, but with the tomotherapy. In this treatment, Dr. Cusimano, the treatment is about 30 minutes. 30 minutes long, and we decide for conventional fractionation of 45 gray in 25 fraction with a simultaneous integrated boost of 55 gray. We can see a two-dimensional reconstruction of target. In the second figure, you can we can see the PTV in red, the PTV, the gross tumor volume, and PTV 55 gray, and in the blue line, the large PTV 45 gray in 25 day fraction daily. Next slide. This is a radiotherapy plan with the ISO dose of 95% of prescriptive dose of 54 gray. Also in this slide, we can see the spare of surrounding cardiac structure. Next slide. And this is isodose of 50% of the dose prescribed, so 22 gray in blue. Next slide. At the restaging patient, we have monitored patient always during treatment with the alter weekly echocardiography and weekly medical examination and blood test. At the echocardiography after radiotherapy show an action fraction of 65%. The CT PET performed in July showed no uptake of a cardiac mass, with minimal uptake of ventricular wall. Next slide. We can see the response, metabolic response of lesion after radiation at the PET-CT. Next slide. At the restaging, patient restarted atezolizumab, and at restaging in October, echocardiography showed no change in mass size, and the PET-CT show a small uptake in the area of heart of surgery and radiotherapy. And the echocardiography of February 2020 revealed a hardly visible mass. Next slide. Patient had progressive lung disease to the bone, brain, and lungs with atezolizumab, and he underwent palliative radiation and died in January 2021 for progressive lung disease with regression of cardiac disease. Next slide. Thank you for your attention.